All right. If you're a trainee on an OB or medicine rotation, you know that page, the one about an abnormal blood count in a pregnant patient. It can be a little intimidating, right? Well, today, we're going to do a rapid, high-yield tour of the most critical hematologic challenges you'll face so you can answer that page with total confidence.
So, here's how we're going to break it down. First, we'll cover the normal, expected shifts in the blood during pregnancy. Then we'll dive into what happens when things go wrong, starting with anemia, then low platelets, those really scary microangiopathies, and of course, the risk of blood clots. And at the very end, we'll boil it all down to the key takeaways you can use on your very next shift.
First things first, before you can even think about spotting what's wrong, you have to understand what's just different. Pregnancy fundamentally changes the body's entire hematologic system, creating a completely new normal.
And this is the core concept right here, hemodilution. The plasma volume, the liquid part of the blood, expands way more than the red blood cell count does. This means the blood is literally more dilute, which naturally makes the hemoglobin drop a bit. So don't freak out. We only start investigating a true anemia when the hemoglobin falls below 10.5. Above that, it's just the body doing its thing.
Okay, so what if that hemoglobin does dip below the 10.5 threshold? Well, now we're moving from normal physiology to actual pathology. And the first thing you have to look for is, by far, the most common cause on the entire planet.
Yeah, the scale of this is just massive. The World Health Organization estimates that up to 60% of pregnant people have anemia. And you know what? The vast majority of the time, it's not some rare, complicated disease. It's simple iron deficiency. It's a huge global health issue that affects both mom and baby.
Now, let's switch gears to a much more complex cause of anemia. For a patient with sickle cell disease, the normal physical stresses of pregnancy can act like a trigger, setting off a whole cascade of really severe complications. It really is a perfect storm.
And the risks here, they are absolutely significant. We see a huge jump in blood clots, dangerous high blood pressure in the lungs, and of course, more of those incredibly painful vaso-occlusive crises. But it's not just about the mother. The fetus is at risk too, with things like poor growth, preeclampsia, and even stillbirth. This is a high-stakes situation that needs a whole team watching very, very closely.
So this leads to a really big debate in management. Should we just transfuse all pregnant sickle cell patients to try and prevent these complications? The jury's still out on that and practice varies. But what's not up for debate is this. The guidelines are crystal clear that you absolutely transfuse for severe anemia that's causing symptoms or for acute, life-threatening events like a stroke or acute chest syndrome. No question about it.
Okay, let's move on from red cells and talk about platelets. One of the most common consults you'll get is for thrombocytopenia, a low platelet count. And your number one job here is to figure out if you're dealing with something totally benign or something much more serious.
And this is the benign one you're going to see most often. Gestational thrombocytopenia, or GT, is the leading cause of low platelets in pregnancy. The key things to remember are, it's mild, it shows up late in the third trimester, and it goes away all by itself after delivery. The bottom line? No treatment is needed. You just watch and
So how do you tell the benign GT from the more serious autoimmune condition, immune thrombocytopenia, or ITP? Well, there are three big clinical clues. ITP usually shows up earlier, often in the first trimester. The platelet count drops way lower, typically below 70,000. And a lot of the time, the patient will tell you they've had low platelets before.
Now, when you're managing ITP, there are three numbers that you absolutely have to burn into your brain. First up, if the platelet count drops below 30,000 at any point during the pregnancy, it's time to treat. That means things like IVIG or glucocorticoids to get those numbers up and prevent serious bleeding. Okay, next number, your target for delivery. To make sure delivery is safe, doesn't matter if it's vaginal or a C-section, you want that platelet count to be above 50,000. This often means you'll start treatment a week or two before the due date to get them there.
And finally, the magic number for pain management. For most anesthesiologists to feel comfortable and safe placing an epidural, they need the platelet count to be above 80,000. So remember those thresholds, 30, 50, and 80. They guide everything you do for ITP and pregnancy.
But hang on, low platelets aren't just about ITP. They can be a warning sign of something way, way more dangerous. And this brings us to one of the most feared areas in all of obstetric medicine, the thrombotic microangiopathies. This is a group of overlapping, life-threatening conditions that you have to diagnose and act on fast.
I know this table looks a little intimidating, but it's super helpful for sorting this all out.
Notice how much they overlap, but also look for the key differences. See how severe hypertension is a classic sign for both preeclampsia and HELP syndrome? But now look at the liver enzymes. They go sky high in HELP and in acute fatty liver of pregnancy, or AFLP. And this one's a big clue. That profound hypoglycemia, that's a huge hallmark of AFLP. Spotting these patterns is how you tell them apart.
Look, while the diagnostic details are complex, the management for these three big pregnancy-specific emergencies is unified, simple, and incredibly urgent. The definitive treatment isn't some fancy drug. It's delivery. You have to deliver the fetus and the placenta. That is the single most important, life-saving thing you can do. Period.
All right, shifting gears one last time, let's talk about clotting. You know, pregnancy is actually pretty smart. It intentionally creates a pro-clotting or hypercoagulable state to get ready for the bleeding that happens during childbirth. But this life-saving adaptation has a dark side, a much higher risk of blood clots, or VTE. And since pulmonary embolism is still a leading cause of maternal death, we have to be on high alert.
So why does the risk shoot up? It's a textbook case of Virchow's triad. Think about it. First, the growing uterus pushes on the big veins, causing blood flow to slow down. That's stasis. Second, the body cranks up production of clotting factors and dials down natural anticoagulants like protein S. And finally, delivery itself can cause injury to the blood vessel lining. It's the perfect recipe for a clot.
So how do we work up a suspected PE without just sending every pregnant patient for a CT scan and radiation? We use a really clever tool called the Pregnancy Adapted Years algorithm. Here's how it works. You look for three things: signs of a DVT, coughing up blood, or if PE is your #1 diagnosis. If your patient has 0 of these, you can rule out a PE with a D-dimer less than 1,000. But if they have even one of those criteria, you need a much lower D-dimer, less than 500, to rule it out. If you can't, then you go to the CT scan. It's a validated way to safely avoid unnecessary imaging.
And if you do find a clot, the treatment you choose is a huge safety issue. Here's the deal. The heparins, especially low molecular weight heparin, are your go-to drugs because they're big molecules and don't cross the placenta to affect the baby. You absolutely must avoid warfarin, which can cause birth defects, and the direct oral anticoagulants, the DOX, because they just haven't been studied enough in pregnancy to be considered safe.
Okay, that was a whirlwind tour. We covered a lot of ground. So let's just boil it all down to the absolute must-know, can't-forget principles that you can take with you to the wards tonight.
Here it is, the high-yield review. Number 1, know how to tell benign GT from serious ITP using timing, how low the platelets go, and the patient's history. 2, memorize those ITP platelet numbers. Treat below 30K, deliver above 50K, epidural above 80K. 3, for HELP, preeclampsia, and AFLP, the answer is always, always delivery. And 4, for blood clots, LWH is in, warfarin and DOACs are out. Seriously, if you remember nothing else, remember these 4 points. So let's end with this. Imagine it. It's 3 a.m., your pager goes off. It's a consult for a pregnant patient, and her CBC is abnormal. After this, you know the key questions to ask, the critical diagnosis to think about. The only question is, are you ready?